Hi, and welcome back. For those of you that are new, my name is John, and I've been a type 1 diabetes patient for about 45 years. I'm also an ED physician in New Hampshire. I spent about 12 years of my life running a diabetes center in northern New York and have spent many hours treating numerous patients with both type 1 diabetes, latent autoimmune diabetes in adults, and type 2 diabetes. I created this video series to help increase diabetes awareness, perhaps provide a little bit of education, and hopefully a little bit of entertainment. I want people to understand that this disease isn't a disease, it's more of a lifestyle. And I want you to respect the disease, but not let it run your life. Life is too short and too much fun to be had to let a silly thing like diabetes rule everything you do. So you may find some hints here, you may find some education, you may find some therapy changes that you want to incorporate. Please talk to your provider before you do any of the above and make sure that you're working with them and they're well informed of your decisions and thoughts. So, last week we spent a significant amount of time talking about the basics of type 1 diabetes. The natural flow would suggest we go to type 2. However, I thought it would help if I broke down some of our major issues that those of us with type 1 deal with. So this week we're going to talk about the anatomy of a low sugar. Low blood glucose, commonly, or I should say professionally known as hypoglycemia, is essentially when the blood glucose slips below 70. Now, these are the textbook numbers. These are the numbers they use in the lab. Some of us may have symptoms before that. Some of us may feel fine at 70 and have symptoms well below 70. So much like this disease and much like our lifestyles, it is very individualistic. What are the causes of low blood glucose? The number one cause is more insulin than glucose in the blood. If you remember our talk last week on the basics of type 1, we talked about the various containers in the body. So this one container, the blood, has a glucose level that ideally for those of us with diabetes is somewhere between 80 and 110, 120. If for whatever reason there's too much insulin in the blood, then that glucose will be driven into the cells and our sugar will drop. Another cause is variable schedules. We may, and I spoke about this last week with the medium acting insulin, the NPH is what it classically was, that spiked midday. If you didn't have that lunch on time, you were certainly going to have a low glucose level. Nowadays, with multi-dose injections, if you inject and find out that you don't feel like eating part of the food that you thought you would eat, you may end up with a low glucose level. You may inject and have lunch canceled, have an emergency meeting at work or something else come up where you can't eat. And because of that schedule change and the extra insulin, you end up with a low glucose level. Another cause, very common, is exercise. Exercise will help induce the muscles to take in glucose much easier. So if we think of insulin as unlocking the door for the muscles to get or for the cells to get the glucose, when we exercise, the cells and the muscles have that door a little bit ajar. They're really hungry. They want to make sure they can run, they can be active, and they can do their job. And therefore, they let the insulin in quicker. And if there's even just a normal amount of they let the glucose in quicker. And even if there's just a normal amount of insulin in the blood, low blood sugars can result. Even if there's, I don't want to say no insulin, but only a basal insulin. So those of you on injections, you only took your Lantus or Tresiba, or those of you on pumps, it's just your regular basal rate, and you haven't adjusted it. You exercise a lot. All that glucose that the basal rate normally keeps in check is now used, and you end up with a low blood sugar. Lastly, as a major cause, alcohol. So alcohol can cause a lot of problems. Its impact on our brain and the way we function. We tend to skip meals or not eat appropriately. The type of drink can certainly impact our blood glucose levels. The fact that it delays the low sugars. So you may have a few drinks with some friends and then 3 hours later have a drop in your blood glucose. Alcohol likes to raise the sugar and then drop it. Another issue with alcohol is the liver gets busy detoxifying the alcohol. That becomes its number one job, as opposed to helping out with the balance of the blood sugar with the glycogen that it stores. So that's not to say don't drink. That's just to understand that alcohol is a cause of low blood glucoses. What does it feel like? does a patient with type 1 diabetes say their low blood glucose feels like? I've been describing it for years, probably not very well, so I appreciate any comments on how you feel, because we're all different. But quite simply, it's very much like an intoxicated person. There's a lot of confusion, there's a lot of sweatiness, often nausea, visual changes, irritation with life, which was always a big one for me. I had to go from happy-go-lucky to instant anger. What other things can people have? Balance issues, coordination gets shot. A lot of that depends on where the glucose level is and how rapidly it's dropping. And everyone has their individual symptoms. I know in college, one of my big symptoms was a cold nose. If my nose was cold, 9 out of 10 times I was hypoglycemic. Don't ask me the physiology behind that one, but it's kind of weird. And we discovered it, and 5 years later, it was gone. Which brings up a good point for those of you with type 1 diabetes, especially if you're new to the game. You may have a perfect understanding of your low blood glucoses, and I commend you for that. That's wonderful. It's going to change. They always change. Doesn't change right away. I think the diabetes gods of the world let you get used to it and know what it feels like, and then they change it. So if something seems off or a little strange, just double check that sensor, double check that glucose level, and make sure it's not a low blood glucose. I've always said diabetes is a real easy one to rule in or rule out just with that blood sugar. So that's pretty much what it feels like. Let's talk a little bit about the physiology. So going back to our containers, we have the container of blood full of glucose, normal levels, let's say 80 to 120. We have insulin on board, which will help get that glucose into the cells so they can use it. We know that active muscle cells don't need as much insulin and get the glucose much easier. Brain cells are also independent of insulin. So the brain is going to get glucose no matter what, and that's not surprising. I think I mentioned it last week or maybe the week before. A lot of our body functions to keep the brain happy. So it's not surprising that the brain doesn't need insulin to get the fuel that it needs to keep the rest of this body going the way we want it to go. The problem becomes when that sugar drops below 70. So below 70, the body starts to get a little bit irritated, okay? Whether it's too much insulin, too much exercise, skipped a meal, what have you. Let's look at what happens in the body. So we're below 70. We start to get a little bit of confusion, maybe a little bit slower than normal. Attitudes might change. Regardless, the brain is not happy with what's going on. The body will respond, okay? The liver is going to the pancreas will talk to the liver, and through a hormone called glucagon, the liver will start taking stored sugar known as glycogen and release that into the bloodstream. This happens in folks without diabetes. It also happens in folks with diabetes. However, those of us that are long term, like myself, or that have had frequent lows, that response may vary. One. Number two, someone that's been dieting or recently diagnosed and had lost a lot of weight might not have the glycogen stores necessary for the liver to help that way. Number three, somebody who has an alcohol use disorder may have damaged the liver so much that it's not going to work. And number four, like I mentioned previously, if the liver is busy with alcohol, it's not going to do this. So newly diagnosed, not in the game terribly long, not a lot of low blood sugars, that liver is going to help out. Patients without diabetes, that liver is going to help out. Next system to get involved is the fight or flight mechanism. So epinephrine gets dumped. And epinephrine is going to give us a lot of our symptoms, our tremors, our sweatiness, our shakiness, our pulse rates go up. We tend to get a lot of anxiety. On top of all the things that we're seeing and feeling, there is also some stimulation to increase the glucose levels in the blood. This response, again, over time can be blunted. We see this with frequent low glucoses. We also see it with long-term diabetes, where that nervous system response, autonomic nervous system response, to be specific, doesn't quite work the way it should. So you have two mechanisms there to help. They don't always work. So let's say it's me. Both of those aren't working very well. Now I drop below 50. So now we're in a new name, a new fancy term called neuroglycopenia. In other words, this guy's got low sugar. Not only does the rest of the body have it, but he's really got it. And remember, he takes priority. So there's where you get your massive amounts of confusion, real balance issue, visual disturbances, convulsions, seizures, and all kinds of issues. Unfortunately, over time, again, time beats us all up, I guess. Over time, we develop hypoglycemic unawareness. So those of you that are looking to get a sensor, this is my big tip for you as a patient and a person that's treated patients for years with this. If your insurance company is giving you any difficulty about a sensor, make sure you talk to your provider about hypoglycemic unawareness. In fact, if they use that term in the note, it will make your life much easier. You're much more likely to get authorization if you can prove with sensor data, which obviously if you don't have a sensor, you can't unless the provider's office has something to help you with that. Or if you can show, even with your own documentation, that you have a hard time detecting your lows. That puts you at a high risk for a lot of issues. And more often than not, the insurance companies will pay for the sensor at that point. So please keep in mind the term hypoglycemic unawareness. It does happen to us. It happens over time with frequency of low glucoses. And like I mentioned earlier, your symptoms can change. So it just makes it a little bit more of a difficult game for us. That's the science of a low sugar. I will take a break here and share, excuse me, one of my actually very recent lows, and I don't have them very often anymore. I was over at the town hall getting a car registered. Had to go back out to my car because I'd forgotten something. As I was walking down the steps to go, I think it was my checkbook I forgot. Go grab the checkbook, I realized my vision seems a little funky. No big deal. You know what? I'll just go across the street, get a sandwich after. I'll be fine. So I go back in, fill out the paperwork, and I get the bill of what I owe. So I'm trying to write a check. And thankfully, the lady jokingly said, "We don't really write checks anymore," because I could barely see to write the check. Not only that, I couldn't remember how much I was writing. So I would look over to see the bill and then come back to the check and completely screw it up. And of course, I'm drenched with sweat. Thankfully, she was kind enough to take the check and could read it enough to make it work. And I was able to get out to the car and get some glucose into me so that I improved. But the vision and ability to balance was going very quickly. The diaphoresis or sweatiness was massive. And after a good handful of Skittles, the glucose did come up. Not the best treatment, but not bad. And I gradually improved. Spent about 3 hours completely wasted. Like I just ran a marathon. Just absolutely exhausted. So that was my most recent one. It was kind of interesting because I don't get the vision symptoms very often. And as I looked at the sensor data, and of course the sensor did alert half a second too late, but I look at the data, the drop was very rapid and well below 50. I would have loved to have a meter with me at that time just to see what the sugar was out of curiosity. But it was an impressive array of symptoms that really hit hard and, kind of woke me up and inspired me to do this video. So back to our plans here. Let's talk about treatment. I mentioned Skittles. I like Skittles because they don't melt. There are so many chemicals, probably most of which are very bad for us on all levels, but they last forever. So this is typically what I find in my downhill ski equipment. There'll definitely be 2 or 3 packages of Skittles. They might have kind of fused together because they're so old. But the bottom line is they are a good source of sugar. What you want to treat with is simple sugars. I've talked about it in the past. Maple syrup is wonderful. Honey is a great one aside from the messiness. A spoonful of sugar will work. You can stick it under your tongue in your gum line. Glucose tablets are wonderful. They're measured, so it makes it a lot easier. The glucose tubes are also measured. We tend to use the rule 15-15, so 15 grams of carbohydrates and recheck in 15 minutes. Those of you taking care of patients with diabetes, good luck with that, because a couple of things happen. When I worked at the Joslin camp, we were very strict with this. We would give 15 grams. We'd let the camper chill for a little bit, and then we'd recheck the sugar about 15 minutes later. If they were doing well, they could go back to whatever they were doing. In reality, when I have a low blood sugar by myself, there's not enough food in the house. I have a real hard time preventing myself from overdoing it. And I'm sure many of you out there do, and I'd love to hear your stories about it. But I have seen times where I will treat with a quick acting sugar, like a spoonful of honey, and next thing you know, I'm on my fifth piece of pizza. And eventually, the brain wakes up and says, "Whoa, slow down, killer! You're going to really pay for this." But many, many times, I've gone from that 40 to 400 without even thinking. So there's that aspect of it. Another thing I grew up with, and some of you may have similar experiences. My grandmother was always extremely afraid of a low blood glucose. She was a smart woman, so she knew and learned very quickly that if I was well fed, I wasn't going to have a low. Boy, did I eat a lot at grandma's house. I think I had 7 hot dogs one day at lunch. It's absolutely ridiculous, incredibly unhealthy, but things to keep in mind. Being a caregiver is difficult because you have your own fears. This is someone you love and care for. You know what's supposed to happen, but you know what can happen, and that can really make things more difficult. Being a patient, there's not enough food in the world. In fact, I did a brief stint with Victoza and another GLP-1 agonist called Ozempic. These are great because they are appetite suppressing, and they worked wonderfully for me after some insulin adjustments. But they worked wonderfully for me in that when I treated a low sugar, I could actually treat with a spoonful of honey and be happy. I didn't feel the need to eat everything in the refrigerator. So something to think about. I at some point we'll talk a lot more about the type 2 medications, including the GLP-1 agonists, which includes Victoza, Ozempic, Trulicity. And I know there's a whole bunch of new ones out there. Bydureon used to be a big one. So another treatment modality to keep in mind. But if you with type 1 or you caring for someone with type 1 have experiences treating a low sugar, I'd love to hear it. If you have hints on how to keep from devouring every calorie you can find, please share, because I find it to be a real struggle. In fact, that's probably one of the top 4 or 5 struggles for me with type 1 diabetes. So that's treatment. Quick sugars, 15 grams, wait 15 minutes, check again. If they're still low, repeat. 15 grams, wait another 15 minutes. I mean, yeah, we overtreat a lot, but we don't want someone to have a seizure. We don't want someone to get hurt because of a low sugar. So I'd rather the person you're caring for or yourself walk away with a 200 blood glucose than keep going with a 30 or 40. So use your heads as best you can, but try to keep that 15-15 rule in mind. As far as preventing low sugars, if we go back to the causes, too much insulin being our number one cause, this has gotten easier because of the continuous glucose monitoring systems. It's very easy to get an eye of where your sugar is, get alarms of a quick drop, get alarms of an actual low. So that's very helpful to prevent. And if you're like some of my best patients, they rarely did much more with the pump except to look at where they were sensor wise. And they loved it. They would check their sensor 20, 30 times in an hour period. But they were able to see, okay, I'm starting to drift down. I'm going to have a little bit of something. Or I need to slow down my activities. They made adjustments. Those of us that are or have been on multi-dose injections, this is adjustments. Thankfully, with the new rapid-acting insulins like the Fiasp, you can dose after the meal, so you know exactly how many carbs you ate. I had this trouble growing up when Humalog hit the market. Humalog it was a much closer to human insulin, much faster acting than regular, and was wonderful. So what I would do is I would say, okay, I'm going to have 45 grams of carbs. I dose for it, and then, I only ate 20. An hour and a half later, I'm on the floor having a low glucose issue. So with these faster acting faster acting insulins, you can have your meal, look back, say, okay, you know what? I ate 35 grams of carbs, dose appropriately, done. Other things to keep in mind is monitoring that fasting glucose. If you're waking up too low, then that fasting that basal insulin, Lantus, Levemir, Tresiba, needs to be adjusted. So keep in mind, I know blood glucose testing is annoying. I know people are horrible with it. The compliance rate on blood sugar testing is ridiculous. But if you're going to pick a sugar to test for, pick the one where you don't feel quite right, and then pick that fasting sugar, typically in the morning for people. Let's see how you're waking up, how you're getting through the night so that that insulin can be adjusted. Adjusting the rapid acting insulin is a lot easier. It's based on activity, it's based on current blood glucose, and it's based on what you're going to eat. So, on that note, another adjustment you might need to do is you just got done running. Okay, maybe you don't need the full dose of insulin for your lunch. Maybe cut back a little bit. Maybe wait till after lunch, even if you're using Humalog or Novolog, because you've got that activity to help enhance glucose uptake. So those are how you adjust the insulin levels, or how you need to pay attention and make adjustments. Alcohol, you want to make sure you have some carbs with you. So the glucose tablets, the glucose gels, some sort of sugar on you. Make sure your friends or family or whoever you're with is aware of your situation and it has the ability to keep an eye on you. Thankfully we use a lot of DDs nowadays. Make sure they're aware. I say, hey, keep in mind, I may need a hand. Be smart about how much you drink. I recommend having something to eat, whether it's some chips or pretzels or what have you, something just to keep the glucose levels from dropping. And remember the lag effect of alcohol. Remember, you may have an issue in a few hours. So, don't hammer 17 beers and then go to bed because you may have a problem overnight. Be smart about it and keep an eye on those sugars a couple, 2 to 3, 4 hours after. So that's our prevention. Let me see what else. If you're going to exercise, cut back on your basal rates if you're a pump user. If you're using the sensor, you can adjust your targets for exercise. If you're injecting, you may want to cut back on your dosing before the meal, or even on the basal. If you know you're going to be running a marathon tomorrow, you may want to cut back on your basal insulin. How about some real stories? Excuse me. I need to get some water here. So, one of my favorite lows, and I may have shared this one before, and I say favorite because I guess my scientific mind, I find these incredibly interesting. And I'm a little bit like Da Vinci. I'm experimenting on myself and just amazed. So I think I shared this one. I used to traditionally in high school, I would get up, take my insulin and blood sugar and all that, have breakfast, go get showered and dressed, and go to school. For whatever reason, this particular day, I got up, took my insulin, hopped in the shower, came downstairs. So I left the lag time. This was before the rapid acting insulin. This would have been probably Humalog. It might have just been Humalin R. But I left about 45 minutes between taking the insulin and eating. I'm also not sure if I even did or remember what my blood glucose was at that time when I took the insulin. Regardless, by the time I came downstairs to eat, I microwaved my egg. I know it's a horrible way to make an egg, but that's what I did. And then I put it on the chair. And then I looked for the ketchup and realized, why is my egg on the chair? In fact, my mother said to me, why did you put your egg on the chair? Did the dog eat it? Boom, right down with a seizure. So rapid drop induced from too much insulin. Thankfully, no, I think mom did have to use glucagon. So I guess I skipped this in the treatment section. I apologize. For those of us caring for folks with diabetes, there's always glucagon. There's a nasal form, there's an injectable form. I always considered it the devil because the blood glucose would go so high from the liver releasing stored glycogen that I would be sick. My kids over time use it as a threat if I was giving them a hard time with a low, and I'll tell you about that in a minute. But glucagon works wonderfully. It's essentially the same hormone that tells the liver to turn glycogen back into blood sugar. So you give it injectable, the liver does it if the liver can. So alcohol use disorder may have a hard time with this. Nutritionally deficient or really thin people that just aren't in a good stage of life may have a hard time with this. Frequent low blood sugars may have a delayed or smaller response. Brand new or fairly new type 1, they're going to bounce back within 10 to 15 minutes. And their blood glucose will go up probably in the 200, 300 range. but they've recovered from the low sugar. They're out of the danger zone for seizures, and they're not going to drop rapidly right after. So that's the basic treatment with glucagon. I mentioned my kids using it. I had one low blood glucose with my kids, and my son put a cold soda, diet soda, on my chest to wake me up. I think what I remember now, I hadn't gotten up to take them to school. So they're downstairs watching TV. My daughter came downstairs, youngest in the family, said, "Hey, where's dad?" My son, I don't know. He was watching TV. He was having a great time. So they came upstairs, found me in bed. So I got a cold, probably Diet Coke on my chest, which woke me up, confused, sweaty. I think my vision was fine. I know my balance was a little off, but the thinking wasn't there. The brain was definitely not happy with me. There was a lot of confusion. My daughter had gotten me some juice and some honey, and I tend to have a very strong independent streak. And I wanted to do it. I didn't want her to help. And plus, she's my daughter. That's my job to help her, not her help me. But regardless, she eventually threatened me with glucagon, and that got me through it. I was able to wake up enough and realize, oh wait, she knows what she's doing. Okay, just take that and drink it, and you'll be okay. So we got through that one. That was a little bit frustrating because I don't like my kids having to deal with it, and I'm sure many of you have similar feelings. One other nasty one with the kids, I was driving them back to their mother's house and drove by their mother's house. And of course, both kids are, what, what are you doing, Dad? And I just kept driving around the block, and I kind of knew things weren't right, so I had grabbed a Twizzler or something horrible. It was probably older than who knows, and was trying to eat that. But eventually, I stopped the car at the park by their house, and EMS was called, and they gave me a tube of glucose and signed me off. No big deal. But it was pretty scary for the kids, and that's something that I've talked to my kids about since. They both have a wonderful understanding of low glucose and the fear that it can cause. Unfortunately, they got that the hard way. But they also understand that it's going to be okay. It's a matter of a Coke, some orange juice, some honey, some maple syrup. It's going to be okay. So that was one of my good ones. I don't remember too many others. I know once as a young child, I scared a neighbor to death when my eyes rolled back in my head. And although he's passed, every time I saw him after that, it was always, "Are you okay? Are you okay?" Didn't matter. 6 months, 6 years later, "Are you okay? You feeling okay?" My eyes will not go back in my head right now. I promise you. So these things happen. It's a low blood glucose. It's part of our life with patients with diabetes. We've gone over treatment. We've gone over causes. Please keep the treatment in mind because that's key. Um, Next week, I think we're going to look at high blood glucose. So that'll be a little bit more in depth and a little bit less fun. I'd much rather have a low sugar. And I know I'm strange for saying that than a high sugar, but it's just something I've gotten very used to dealing with when I know the symptoms. That when the symptoms change a little bit, I need a good week or so to adjust. But recognize the symptoms, test, use your sensor. The sensors have made this incredibly rare, which is wonderful. Keep on top of it. Keep on top of how you feel. In medicine, we say treat the patient, not the number. And I'll say the same thing to you folks with diabetes. I understand that number may look fine, but if you're not using a sensor and you're just testing your glucose, you may be on your way down. Your body's talking to you. Listen to it. If you see an 80 and you're just not feeling right, don't assume you're fine, because I guarantee you within 15 or 20 minutes, you're going to be 60 or 50. So if you're feeling low and your number's looking a little bit in the southern end of normal, go ahead and treat. It's okay. You can always compensate with insulin later if you need to. So please, if the sensor is saying you're dropping down and you're feeling it, it's okay to treat before you hit the low. Our goal is to prevent them. So that's all I got for you this week, folks. I hope this was helpful. Please share your stories, like, comment, and subscribe. I'd love to hear some good low stories or some good low treatment ideas. Or how do we not eat everything in the fridge? That would be wonderful. Thank you all and stay healthy.